So this session we're going to talk about pharmacodynamics. So pharmacodynamics is a chapter which deals with how the drug produces its action. Okay, whatever the drug does. Some drugs might relieve pain, some drugs might reduce temperature. So how they do this action? What is the mechanism by which they act? So pharmacodynamics is nothing but it's a study of action of drugs on the body and their mechanism of action. That is to know what the drugs do and how they do it. Okay, what they do and how they do it. So drugs can act by stimulating a receptor, depressing a receptor, by causing irritation to the surface of the nerves, by replacing something, by anti-infective or cytotoxic action. That means it can kill another organism or it can kill a cell, or by modifying an immune status. So mechanism of action of drug can be via receptors, through enzymes or pumps, through ion channels, through transporters or symporters. It can block a transporter or a symporter, or it can stimulate a transporter or symporter, by physically blocking a drug, by chemically interacting with the drug, or by altering the metabolic processes. So through receptors, there are different types of receptors. If you see here, this is an ion channel. GPCR. GPCR stands for G protein coupled receptor. G protein coupled receptor. Okay. Then we have kinase linked receptors and nuclear receptors. So under ion channel receptor, what happens is the ions can come inside the cell from the outside. It can cross the membrane, come inside the cell. It can cause hyperpolarization or depolarization, and it will lead to some cellular effects. GPCR, it's a G protein coupled receptor. It has got a 7 transmembrane structure. This is a 7 transmembrane structure and 3 subunits, alpha, beta and gamma subunit. So it will convert GTP into GDP, and it will activate second messengers like cyclic AMP or cyclic GMP, and it will cause phosphorylation of proteins that will in turn lead to cellular effects. Kinase linked receptors, by activation it causes protein phosphorylation and they will cause cellular effects. And nuclear receptors, the receptor will be present inside the nucleus. So the ligand or the drug will come and attach to the receptor which is present inside the nucleus, and they will alter the protein synthesis, which in turn will lead to some cellular effects. So receptor families, if you see, this is the same thing in a flowchart form. So first we have GPCR, then we have ion channel receptors or ionotropic receptors, then we have transmembrane receptors, which can be into 2, which are connected to enzymes, which are non-enzymatic transmembrane receptors, and fourth we have nuclear receptors. So under GPCR, if you see, there are 4 subcategories: GS, GI, GQ and G12/13. So GS means it is a stimulatory receptor. If you stimulate, whenever you stimulate the receptor, it is going to have a positive action. GI is, it's an inhibitory receptor. Q is, it causes phosphorylation. G12 and 13 are thrombine receptors. So GS, it activates or increases adenyl cyclase enzyme. So one example is beta receptors. GI and GQ, they increase adenyl cyclase or phospholipase enzymes, ion channels basically. Example is muscarinic receptors. G12/13, as I already said, it's a thrombine receptor. Ion channels, they can be either ligand gated or voltage gated. Ligand gated means once a drug or a ligand comes and binds, the channel will open or close. Voltage gated means whenever there's a change in the voltage of the cell membrane, the channel will open or close. So for ligand gated, it can be either sodium, calcium, potassium or chloride. Example is nicotinic receptor. For voltage gated, it can be sodium, calcium or potassium. Example is lignocaine or calcium channel blockers. For transmembrane receptors, we have kinase linked receptors like insulin receptor. For transmembrane non-enzymatic receptors, we have cytokine receptors like JAK-STAT receptors. JAK stands for Janus kinase. JAK, J-A-K stands for Janus kinase STAT receptor. Example is interferons and cytokines. For toll-like receptors, we have IRAK receptors. IRAK stands for interleukin receptor activated kinase. IRAK stands for interleukin receptor activated kinase. This is not under use currently, it is under research purposes still. Under nuclear receptors, the drug receptor complex moves into the nucleus and directs the protein synthesis. So, example like the hormones, estrogen, steroids, thyroids, and PPAR, peroxisomal proliferated activated receptor, gamma. This is an anti-diabetic drug receptor. So, there are basically 4 types: ion channels, GPCRs, transmembrane, and nuclear receptors. So, receptor regulation. These receptors can either increase in number or decrease in number. So, if they increase in number, it is called as upregulation. If they decrease in number, it is called as obviously downregulation. So, upregulation, what upregulation actually means is, so prolonged deprivation of agonists or constant use of antagonists to the receptors, or the nerve supply that supplying the region of the receptor is lost, denervation. It can cause increase in the number of receptors, that is, there will be increased sensitivity. The number of receptors will increase. Thereby what? Whenever a small agonist comes, it's going to have an exaggerated response. So there will be increase in response. Example, angina following sudden withdrawal of beta blockers after prolonged use. So whenever you stop a beta blocker suddenly, it's going to have some rebound effect, rebound hypertension or rebound angina. All that is because you're constantly blocking the receptor by giving a beta blocker. So suddenly if you stop, what will happen? Exaggerated response will be there. So this is upregulation. So what is downregulation then? Prolonged use of agonists or continuous stimulation of the receptors or denervation again can lead to decrease in the number of receptors and decreased sensitivity of the receptors. Thereby the response is going to be reduced. So reduced response to beta-2 agonists, prolonged use in bronchial asthma. So when you continuously give beta agonists in bronchial asthma, the response to the drug will reduce because you are continuously stimulating the receptor, so the receptor sensitivity will come down. Drug potency and efficacy. So what is the difference between potency and efficacy? Now if I say, say for example, we'll take drug B. Okay, drug B is the most efficacious drug. So this is, now if you see, the x-axis is dose of the drug and the y-axis is response of the drug. So dose means, say for example, we'll take this is 1 mg, 2 mg, 3 mg and so on, 4 mg, 5 mg, like that we'll take it and so on. And the response we'll take it as 10%, 20%, 30%, like that till 100%. Okay, we're just assuming. Now if I say drug B has got the maximum efficacy, that means what? This has got 100% response, correct? Maximum efficacy means 100% response produced by any drug. So, the maximum response that a drug can produce at any dose, irrespective of the dose, is called as the drug efficacy. Okay. Okay. Then what is potency? Potency means the smallest possible dose that will produce any response. That any response needn't be the maximum response. It can be the minimum response also. So the smallest possible dose that produces any response in a drug is called as potency. Now here, which is the most potent drug? Which is the smallest possible dose? 1 mg is the smallest possible dose. So drug A, if you see, at 1 mg, it is producing some response. Some 30% response is seen. Correct? So out of all the 4 drugs, drug A is the most potent drug. Okay. So amongst all the 4 drugs, which is the most efficacious? Drug B, most potent? Drug A. Now, if you compare drug B and drug D, which is a more potent and more efficacious? Drug B. Okay. If you compare A and C, which is more potent? A. But which is more efficacious? C. If you compare A and D, which is more potent? A. Which is, they almost have the same response. So, the efficacy is the same, but the more potent one is A. Okay. So, once again, efficacy is the maximum response that a drug can produce at any particular dose. Potency is the smallest possible dose that a drug produces any response. Okay. Therapeutic index. Therapeutic index means what? There's a formula for it. So therapeutic index is equals to LD50 by ED50. So therapeutic index of a drug tells us how safe the drug is. Okay. So LD50 by ED50. LD stands for lethal dose. ED stands for effective dose. This 50 is 50% of the experimental animals. So this therapeutic index will be determined at the experimental stage of the drug itself. So LD50 means the lethal dose in 50% of the experimental animals divided by effective dose in 50% of the experimental animals. So if therapeutic index is more than 1, the drug is considered to be safe. That means even if there is an accidental overdose with the drug, nothing much will happen to the patient. But if the therapeutic index is less than 1, then the drug is considered to be unsafe. So you have to be very cautious while giving the drug, and the dose titration and the plasma concentration of the drug, everything has to be maintained at a particular range. If it is going above, it is definitely going to cause toxicity and it is not good. If it is going to go below, then the response of the particular drug will not be there. It is going to have loss of efficacy. So this area in between curve A and curve B is called as the therapeutic window. So those drugs that have low therapeutic index should maintain a plasma concentration between these two curves. That is, the blue one is where the efficacy of the drug starts, and between the two curves, this efficacy is there. The efficacy is maintained. At the red curve is where the unwanted side effects will start. So if the drug concentration goes beyond this, then there's going to be unwanted effect, that is toxicity. If the drug concentration is less than this, then it's going to have no therapeutic response. So it is mandatory that we maintain the concentration of the drug between these two levels. So that is called as a therapeutic window. So therapeutic index tells us about how safe the drug is, and the formula is LD50 by ED50. So drug antagonism. What do you mean by antagonism? Antagonizing something means one drug affects the response or reduces the response or abolishes the response of another drug. How it can be done? So one drug opposes the action of the another drug. It can be chemical. Two drugs interact chemically. Now say for example antacids. Antacids are a chemical component which will act with acids, that is a hydrochloric acid. There's a chemical interaction between these two agents, so it nullifies the effect of hydrochloric acid. So chelating agents with heavy metals and antacids are also examples for chemical interaction. Physiological. Two drugs act at different sites. Okay, they act at different sites, but the actions are opposite to each other. They act at different sites at their respective receptors. They are in no way in connection together. They act at different areas at different receptors, but the end response is opposite to each other. Example, histamine and adrenaline, insulin and glucagon. Histamine will reduce the BP, adrenaline will increase the BP. Similarly, insulin will reduce the blood glucose level, whereas glucagon will increase the blood glucose level. So through receptors. So antagonists bind to the receptor and prevent the agonist from binding. This binding of antagonists can be reversible or irreversible. Like for reversible, we have acetylcholine plus atropine at muscarinic receptors. For irreversible, we can give the same example. OPC compounds with the acetylcholine receptor. Irreversible, another example is irreversible adrenaline and phenoxybenzamine at alpha receptors. Non-competitive, that means antagonists act beyond the receptors. They do not compete with the same receptor. Like say for example, here is a receptor. Okay, this is a receptor. So we have our agonist here. This is our agonist and this is our antagonist. So antagonists usually they compete with the agonist and they come and bind here. Okay, they push the agonist away and the antagonist come and bind. This binding can be reversible or irreversible. Reversible means it will detach itself again from the receptor site. Irreversible means it will stay attached with the receptor till the end because of the difference in the bonds. If it is reversible, it attaches with the hydrogen bond. If it is irreversible, it attaches with the covalent bond. Okay. Now, they are competing. No, there's a competition between the agonist and antagonist. Whereas there can be non-competitive antagonism. That is, the antagonist doesn't bind on the same site. They do not compete for the same site of the agonist. They bind to some other site, but still they produce antagonistic action. Like example, verapamil calcium channels. So moving on to adverse drug reactions. What do you mean by adverse drug reactions? They are unwanted reactions that happens because of a drug. Like say for example, now we give paracetamol for most commonly treating fever. So what do we expect from paracetamol? Just to reduce the fever. But apart from doing that, if it causes some other gastritis or gastric problems, that we do not want, right? We do not want that along with paracetamol. Such kind of unwanted effects that are produced by the drugs are called as adverse drug reactions. So they can be of different types. So this could be used as a mnemonic: A, B, C, D and E. 5 types of adverse drug reactions. So A for augmented, B for bizarre, C for chronic use, D for delayed use and E for end of use. Okay. So under type A we have side effects, secondary effects and toxic effects. Under bizarre, that is, these effects are understandable, that is, they are the actions of the drug. Like say for example, you are giving beta blocker for treating hypertension. So what is expected? They will reduce the BP. So if the same drug causes hypotension, then that becomes as the type A, augmented effects. It is augmenting the action of the drug itself. Nothing unknown. It is known. Beta blockers are known to reduce BP. So that is why they are given in hypertension. If they cause hypotension more frequently, then it becomes as an adverse effect. So that is called as an augmented effect. Bizarre. Bizarre means you cannot understand the mechanism why this adverse effect happens. It's very bizarre. You don't know why it happens and to whom it happens. It can happen to anybody. Not all patients will experience this type B adverse drug reaction. It can happen only to a few patients. So this can be allergic reactions or idiosyncratic reactions. Allergic reactions, they can be immunologically mediated. Hypersensitivity reactions basically. Type 1, anaphylaxis due to penicillin or lignocaine. Type 2, antigen-antibody complexes like anemia due to carbamazepine. Type 3, Arthus reaction, again antigen-antibody complexes like sulfonamides. Type 4, delayed hypersensitivity, T-cell mediated like in penicillins. Idiosyncratic means those patients who are genetically susceptible to those adverse drug reactions will develop these. Not all patients will develop bizarre adverse drug reactions. So most commonly that we can remember here is this SJS, Stevens-Johnson syndrome. SJS stands for Stevens-Johnson syndrome due to sulfonamides or carbamazepine. Type C. On chronic use of the drug, you get this adverse drug reaction. Okay, when you have to use this drug for a long duration of time, like say for example, calcium channel blockers like amlodipine can cause gum hypertrophy. For that, you have to use the drug for a very long duration of time, like say for example 10 years and 15 years. Those kind of duration can lead to such adverse effects. Delayed use. You use the drug now, but the effect is seen after many years. You have stopped using the drug, but the effect is seen after many years. Like say for example, a pregnant mother who has taken stilbestrol, some estrogen supplements, okay, during pregnancy, the female child born to that mother can develop ovarian cancer in her days, okay, in her adulthood. That is called as delayed use. The mother is not affected. The female child, if at all a female child is born to this mother, then the female child will develop ovarian cancer later in life. That is called as delayed use adverse effect. End of use. Once you stop the drug, the adverse effect pops up. Like say for example, you are taking beta blocker and suddenly you are stopping. Then there is rebound hypertension. That kind of adverse effects are called as end of use adverse effect. So for all these, you have to be very careful. No, augmented is the one that we already know. We already know this drug produces this action. Exaggerated response becomes type A or augmented. Bizarre is unexpected reactions. It can happen to anybody. Not all patients will develop bizarre reactions. Chronic use, you have to take the drug for a long duration of time for the adverse drug reaction to develop. Delayed, you take the drug now, you would have stopped the drug also, but the effect will be seen later. This is a case where teratogenic agents have their effect, or carcinogenic agents can have their effect. And end of use, once you stop the drug, the adverse drug reaction comes. So these are the types of adverse drug reactions. So to summarize, in this chapter, the most important question that they can be asked is drug antagonism, adverse drug reactions. These are the most common types questions that can be asked. So types of receptors, there are 4 types: ion channels, GPCR, G protein coupled receptor, transmembrane receptors, and nucleus or nuclear receptors. Okay, nuclear receptors. Therapeutic index can be a short note. So therapeutic index tells us how safe the drug is. It has a formula LD50 by ED50. There is a therapeutic window within which you have to maintain the concentration of a drug in order to have its proper efficacy. If it goes below, there will be loss of therapeutic efficacy. If it goes above, it will cause toxicity. Drug antagonism: one drug nullifies or opposes the action of another drug. It can be because of various mechanisms. It can be chemical antagonism, physiological antagonism, and receptor mediated. Receptor mediated can be again competitive, non-competitive. This competitive can be again reversible or irreversible. Types of adverse drug reactions: we have 5 types: A, B, C, D, and E. A stands for augmented, B stands for bizarre, C stands for chronic use, D stands for delayed use, and E stands for end of use. So remember this chapter, drug antagonism and adverse drug reactions, they are very important. These are the important questions that can be most commonly asked in exams.